your website?
Yeah, where do we post it, Alice? So where will it be posted? So we'll start the recording and
we'll post it on the Your Voice website,
Yeah.
which is our engagement platform. We can share that link with the list of people who've attended this once we've got it up and live. That would probably be we can probably put that up tomorrow.
That's perfect. Thank you very much.
No problem.
Yeah, thank you. Thanks. Okay, in that case, then I think we'll kick off. I'll bring Louise in, who's going to run through a summary of the presentation and the strategy document. Okay, thanks, Louise.
Thank you, Abid. Good evening, everyone. So those that have just joined, I'm Louise Smith, and I'm the Deputy Director for Primary Care in Bob. I hope you've had a chance to have a look through the strategy. Don't worry if you haven't. We'll run through a very summary version of it this evening, and hopefully it'll only be sort of 10-15 minutes, so we have lots of time for questions. So if we can move forward, do I have control of this? Oh yes,
Alice,
I think I might have been able to do it myself. Sorry, thank you. So the strategy absolutely comes from a good place. We recognise how important primary care is to our system and to our patients. And when we talk about primary care, we are talking about not just general practice, but dentistry, pharmacy, and optometry as well. We're very lucky in Bob. We have very high quality services, but we do have variation in some of that provision, and we have workforce gaps that are widening as time goes by and a significant workload. So we're also looking nationally to see what the national direction is for primary care, and it is absolutely to integrate more with other services such as communities services, the acute trusts, our voluntary and charity sector. So we've taken these components and we've tried to address the challenges and support integration in the strategy that's presented. And what the strategy also does is try and provide you with an idea of how we might go about doing some of that. There we go. So this is what I like to call our happy slide. This is all the stuff that we think is going well in Bob, and it's got some really good things on it. So I've already said about the quality of our services. When it comes to things like community pharmacy, we've got really interested community pharmacy, and they're really keen to work with us on some of the more innovative approaches to health, like our Pharmacy First initiative, which you may have seen in the press quite recently. We're also really good at focusing on our inequalities, getting that prevention perspective, but then also using the data to do that. So we call that population health management, but really it's using the data in an intelligent way so that we can understand your health needs better and provide better services. When I said earlier about the community pharmacy and being quite innovative, our dental practices equally are like that, and so are our optometrists, and we're starting to get pockets of what we call flexible commissioning, but it's basically additional provision which is working differently within their current contract to ensure that they focus on those that are most vulnerable and ensure more NHS services are out there. So that's really, really positive. And then our final strength there that we've thought worthy of you knowing is the fact that our general practices are also very good at working at scale. It's been going for a few years now, and you might have heard of primary care networks, but we also have something called GP federations that are even at a larger scale. And now that we have our pod colleagues coming in, we're starting to build that relationship between general practice and our pod colleagues. So it's all good stuff. I think Obviously, we wouldn't be doing a strategy if we didn't have some challenges, and really they're focused on the fact that we've listened to our patients. We know that their experience of primary care isn't as positive as it could be, and we'd like to do something about that. We know from doing several staff surveys that our staff in primary care also are not as happy as they could be. They feel under extreme pressure. Some of them are suffering burnout, and it's making going to work not as positive, and some of them are choosing different types of career in primary care, so what we call portfolio career. So they'll only work a couple of days rather than the full week in primary care, and some of them are leaving altogether. The third issue is this, what we call a mismatch between the demand for services and the capacity. So what that means is that lots of people are coming through those doors and we just don't have the service to match that, and we need to address that dynamic. And the reason that's so hard is that capacity is difficult to build. It requires workforce, recruitment, retention, it requires funding, it requires estates to be on as good as it can be. So they're all significant challenges. So this slide, really simple. Our shared vision is that everyone in Bob has the support they need from primary care, and primary care will work in a coordinated and integrated way with other system providers so that they can support people to stay well. So prevention where we can. So some of those elements, so it's ensuring that people can get the right support first time. So when you meet a health professional, it's the one that you actually need to see rather than going through several different people. Changing how we work so that we can enable that. And then providing personalised proactive care for those with complex needs. And I'll talk about that a little bit in a moment. So this is quite a busy slide, and I think if you just look down on the lower half of the slide, and it describes our future vision. So this really is about self-management. So where we can, supporting our communities to use tools like the NHS website to signpost, and to be able to self-care. You might choose to go and use a pharmacy first, rather than going directly to your general practitioner, and staying well for as long as you can. But actually, if you do need to ring in to a practice, we're looking at things like triage, where we're able to look at your needs and then stream you into the most appropriate care. And then initial contact, obviously the right professional, whether that be a virtual or a face-to-face appointment. So we recognise that not everything will be face-to-face. This slide, again, quite a busy slide, but what this shows, and I think if you look at the box on the right, what it shows is the type of professionals that would be part of your care if we started to establish integrated neighbourhood teams. So these would be teams of healthcare professionals centred around the patient with the GP involved, and it would mean that you would see this right professional at the right time, and that might be a mental health practitioner, it might be a physiotherapist, it might be a social worker, it could be a dentist. So it's ensuring that that team is built around the patient. This slide, we do like busy slides in the NHS, but this really is about how we use the data so that we can understand our population better and we can target the support for everyone, which I mentioned a little bit earlier. So what we're keen to do is to ensure that we're looking at health behaviours and trying to prevent the long-term conditions from developing over time in the first place. So this is a really important part of our strategy. In order to deliver on all of these things, we are going to require workforce. And I've already spoken about the challenges with our workshop, but we need to ensure that we have a workforce that's robust and resilient. We need to ensure that we're recruiting in the best professionals and actually growing our own as well. We want to make Bob an attractive place for people to come and work. We also want to make it adaptable so people can flex across the system, so people can go and work in primary care, but actually if they're needed elsewhere, they could also work there as well. And I think a big part of this is how we use our resources a bit smarter. So it's not just about money. So sometimes it will be about people working differently with what we've got. Digital and data, I've emphasised our focus on data to use it intelligently so we can recognise people's needs, but also understand how services are doing and support where we need to. And that final box, really important, is our estate and ensuring that it's fit for purpose. So this is a nice slide. These are our 3 priorities for delivery. First one here is non-complex same-day care. So what we mean by this is that those that are relatively well don't usually go and see their GP. That could be, we'd know that when they ring in, we'd understand that they are not usually ill, and actually we could stream them off to be seen in a slightly different way. By doing so, we would hope that we could release some time for general practitioners and their team to provide that continuity of care for the patients that need it. So the complex individuals. Linked to that is our integrated neighbourhood teams, built around those that do have more complex needs. And as well as a proactive element, it's also about personalised care to that individual's needs. And the third element is the cardiovascular disease prevention. So prevention is really important. We've actually focused on CVD, cardiovascular disease, in our slides, mainly because we recognise it as a significant issue in Bob, and it comes with other consequences. It impacts on your wider health, and it's something that we could prevent if we're working together in a slightly different way. So it's also one of our system priorities. So we would be working not just in primary care on working to improve CVD, but so with our acute trusts and our community trusts and our voluntary and care sector as that first push. That's not to say we won't be focusing on other things. This slide just outlines some of the things that we're currently doing that we won't let slip while we're moving forward with our primary care strategy. Some of the things we're doing in general practice around the NHS app and our recovery plans for primary care. I've already mentioned the Pharmacy First rollout and the optometry initiative. So I think if you have a bit of time, just read through some of that good work that we're already doing and will continue to do. And I think that's it. So if you have any questions, feedback, please feel free.
Thank you, Louise. So a lot of detail, obviously, on the full strategy document. So that was a kind of a summarized version. So thank you for taking us through that. So yeah, I did say you can post in the chat. Apologies, the chat is turned off. So it's the question and answer button, I think, and there are some comments coming through on that. So that's where you can feedback and. But I'll take questions now. So as I said, this is a new way of doing it. So I just need to have a look at my control panel, and hopefully I can see whose hand is up. So we've got Joan Stewart first. So if we can, yeah, there we go. So Joan, yeah. Sorry,
Joan, are you able to switch your mic on?
I think she's struggling a bit there.
Can we do it from our end, please?
We can't switch the mic on. I've allowed her to be able to.
Okay, yeah. Joan, are you managing that?
Joan, no? the mic's on the top. You see the menu along the top. You see Mick. If you just press MIC Mick, just press on that and it'll unmute you.
There we go. Is that it?
Yeah, that's it. We can hear you now. Perfect. Yeah, excellent. Right,
Sorry.
Go for it.
There's always someone.
That's all right.
The number one priority, yes, non-complex same-day care.
Yeah.
Yep. And I wonder what concerns you have about LMCs in England rejecting that breaking up of GPs' work, that they feel that continuity of care and the GP relationship, patient relationship, will be harmed by this. They want to keep, my understanding is, that they don't want to separate acute on the daycare from planned general practice care. So that would be my first question, if the doctors aren't for it. And the second one is that you'll be aware that the BMA this month published a survey of about 80,000, well, they got 80,000 responses to their questions about MAPs, the physician associates, and that what they came out with was that they're really concerned, particularly on patient safety from the way that PAs are being employed. And that I think it's also been taken out of their hands about the GMC, because they're, I think, going to now regulate them, whereas the BMA didn't want that to happen. So here we've got doctors saying that that they're trying to warn the government that they shouldn't go down this route. But it seems as if, looking at the problems that we have, certainly in Oxfordshire and across the Bob in terms of the workforce, it looks as if there's going to be, what, 10,000 more of these PAs in the pipeline, which means that people turning up at these hubs are unlikely to see a GP. And so for many patients, we're really concerned that if doctors are concerned, then we certainly as patients should be concerned. And so, you know, I'd welcome your thoughts on that.
Yeah, thank you. And some really good points. So I'll take the first point around about separating planned and urgent care. So what we're not proposing is a whole-scale split of elective, like you do in hospitals, planned and urgent. So we're not saying that all urgent care. What we're proposing is to relieve the pressure on the system, because there's not enough GPs and to see everything. So that's a fact. We know that. That's been considerable for some time. So what we're saying is we want to release some of that pressure, like a pressure valve, and use some of our other allied healthcare professionals to do that in a sensible way. Actually, increase continuity where continuity is actually really needed. So for those patients who are moderately unwell or have multiple long-term complex conditions, so actually those patients will get more time. That's the idea, with preventative care, wraparound care. So I think that will help, I think, in the first instance. And regarding the concern around physicians associates and other colleagues, so I understand there's been a lot of press around that. I think there's varying views. I think under supervision and properly managed, these are highly skilled professionals who can add to help with that workload. Because again, we've got to have GPs working at the top of their license. I shouldn't be dealing with sore throats and simple UTIs and things like that. We've got pharmacists, we've got paramedics, we've got physicians associates. We need to be utilizing this clinical workforce because we haven't got the numbers. In an ideal world, yes, we could do that. But I think the plans that we've set out will increase continuity for the right patients, continuity that matters, and we'll use technology to do that and make sure those patients are getting the safest care possible. So hopefully that will address some of your concerns. Thank you. I'm going to move on to the next question. So let's just go to.
Okay, it's me. Thank you very much.
Yeah, thank you. Thank you. Yeah, I think.
Okay.
Dr. Yeah.
Can you hear me all right?
Yes, I can. Yeah, yeah.
So I'm Liz Perrotts, and I've been involved in Keep Our NHS Public. I'm now the chair of it locally. And so I'm a historian of the NHS. So I've worked in primary care in the hello Julie. We've worked together in the past. I've got 3 key questions here about this strategy. I feel your pain. I feel that, but I really think it's important, particularly with the possibility of a new set of political will coming along with a new government, that we don't lose sight of what excellence actually looks like. And excellence, in my mind, actually still looks like the GP, somebody who is a general practitioner, being responsible for actually looking at any person that comes through the door with a problem and knows his community, knows his set of people who are able to get to his surgery. And I think that a lot of your strategy, the one that you've put forward in all your pain and trying to rise to the challenges, will disadvantage people like my 91-year-old neighbour who won't have a clue how to do anything to do with this. And I think it will lead to mistakes, because the second part of my question is, how do you make certain when people are diverted to, for instance, to go to see the eye person first, who at the moment, a lot of our eye people are outsourced, so they're private companies. Now, I know, because I go to these private companies, that they'll do my free eye test, but they'll then say, oh, and wouldn't you like this? And what about that? And you end up with being overprescribed. Now, that is not what any of us want, is to have people who are oversubscribed. So I want to know what you think about that. And the third thing is, if you set up, and I've indeed written a paper when I was with the health authority, I wrote a paper on why hospitals at home was such a good idea. If you concentrate most of what you're doing on the people who have been diagnosed as chronically ill and need to be expert patients, and divert yourself from the front line to that, you are actually going to just make a whole lot more chronically unwell people, and make a whole lot more people who cannot get seen, or get seen by a physician's assistant who doesn't see what's going on. Surely that is not the way to go either. I'm sorry to take up so much time, but it's something I feel very passionately about indeed, as you can hear.
Yeah, thank you for that, and thank you for obviously sharing us with your vast experience, as you said. So I think, look, what we're trying to do is make sure that patients get a joined up care as possible, and I think the strategy will help. Certainly, you mentioned your neighbour who's 91 years old. We would hope in the new world that actually he or she gets a better care service of care, level of care, with the right team, a neighbourhood team looking after them, wrapped around with care coordinators, district nurses, whoever's involved in that patient's care, with the GP at the center of that, managing that much more closely perhaps than they may be able to now, where they're trying to do everything and perhaps not delivering it as well as possible because they've got 70 contacts or 80 contacts in the day. So I think I'm hoping that this will actually deliver a better level of service for that patient and other patients in a similar situation, you know, with those neighborhood teams. And we want to change the model because at the moment, it's just simply all not doable. You know, I think in an ideal world, as I said, you know, it'd be great if I could deal with everyone and everything, but simply we know the numbers are not there. We know that's not possible. We've outlined the pressures that are out there, and we're trying to recruit more GPs. Don't get me wrong. We're not saying that we're not going to be recruiting GPs. That is still primary. We want to recruit. Actually, in Oxfordshire, the trainee spaces are actually full. There's competition to get in, so we're getting the junior doctors in, but we've got to make sure we retain those. We've got to have smart job plans. We've got to have exciting job plans for the new modern GP. Who perhaps doesn't want to, you know, join a practice and stay there for 50 years. They want to do different portfolio careers. We've got to make sure we've got to retain them. We've got to keep them, and we've got to make sure the workforce we've already got stays and has a good work kind of life balance as well. So I think there's a number of strands here, but hopefully, you know, it joins up. And as to your point around kind of, you know, going to like the eye doctor first or the eye people, I think, you know, again, we've got a number of clinicians in the community and pharmacists and eye people. And what we're trying to do is, to your point about connectivity, we understand at the moment the system is disconnected. You're right. And one of the things we're certainly working on through the strategy and the vision is how can we connect all the, you know, the dentist, the pharmacist, primary care physician, so everybody knows what's going on with the patient and there's no duplication, nothing is missed off in the handoffs, and actually we're delivering a better service. So that requires good IT systems and systems for connectivity. And we're actually in our patch, you may know this, we're way advanced in a lot of systems out there where we've got something called connected care, which joins up patient data and helping us kind of look at patterns and look to see where we need to commit resource, reduce health inequalities, target patients specifically. And we want to advance that so that all the systems connected up much better across the whole patch. So I think you make some excellent points, and you know, I think all those points we hope to pick up in the detail of kind of delivery. So yeah, thank you. Okay, so I'm going to move us on to
Abid.
Yeah.
Do you think we've got quite a few questions coming into the Q&A?
Right.
Could we maybe take a minute just to go over a couple of those?
Yeah, sure. Yeah. Do you want to point them out to me? Sorry.
Yeah, sure. So we've had a question saying, surprised not to hear more mention of a change in the proportion of funding spent on PHC and public health prevention versus SHC, something that ICB should actually do to make a difference because the required changes do need resources.
Yeah, I might bring Louise in on the finance question. Louise, do you want to?
Yeah, I mean, there's a limit to how much we can do with outwardly stating financial changes within a strategy. So this is a direction of travel with the services that we have. As we progress the delivery of this strategy, we do need to start thinking about actually those other conversations that frame it, like resourcing. The problem with our resources at the moment is that we don't have enough to go round. So everybody's really keen to hold on to what they already have. So our working together is likely to be more around a different approach to care, people working collectively together. But we certainly want to focus more on prevention where we can. But we haven't got onto that budget topic.
Yeah, thank you. And there's a question about, you know, what will the neighbourhood teams, you know, there's a comment that, you know, the patients had 10 different consultations with 10 different GPs. Yeah, I agree, it isn't satisfactory. And I'm hoping certainly where there's complexity with care coordinators in practices, you will get a better, more joined up service. So in my practice, we have a care coordinator when patients, especially complex patients or frail elderly or complex patients are discharged from hospital, they get a phone call, we check if they're okay, we check if they need anything, if the GP or the nurse needs to input into anything, liaise with their relatives and carers, and make sure, you know, they're getting a good level of service, and they know that if they've got a problem, they can come to that care coordinator and contact them, the family member of the carer, and make sure that's flagged to the GP, who can sort things out in a smooth way, so they're not being bounced around the system. So, and I think a lot of practices have care coordinators in place now. So, so a lot of these neighbourhood teams are to be defined, and we want to set the principles of how we think these might work and operate for different cohorts of patients. So you could have some for children, you could have some for elderly. Another question there says, why is diabetes not a priority? So so a lot of things are a priority. So we've tried to keep the strategy as manageable as possible. So it's not to say we're not working on diabetes. Diabetes is a priority. It's just these are the three key big things we're going to be focusing on. Diabetes is a big priority because we've got a significant kind of public health matter there, and we need to obviously prevent people becoming diabetic, and the long-term conditions part of the organization has got lots of things going on with diabetics and care around diabetes, education, and so forth, and a lot of it certainly is about making sure patients with pre-diabetes don't ever become diabetic. So there's a big strand around there, so I can assure you that we are doing a lot of work on diabetes. So I'm going to go back to the hands. Let me just bring up my list. Right, okay, because this, right, so I've got, no, I'm going to pronounce this wrong.
Should be John Bosco.
Yeah, sorry, yeah, John Bosco, yeah, apologies, yeah. John Bosco. Are you able to unmute yourself? Yeah, so top mic, so the mic button on the top right of your computer.
See the menu along the top,
yeah.
John, and then under mic, just click the mic so you unmute yourself. Have you got that?
No? Okay, I'll come back to you, John. So you have a look. I'll come to Carly then, and then I'll come back to you, John. Carly Warner.
Hi there. Hello.
Hiya.
I'm part of Oxfordshire LOC, which some people might know as the Local Optometric Committee. So I have got just a couple of questions. We haven't really prepared anything for you guys, but lovely to meet you all. First of all, I just wanted to comment on Dr. Peretz's queries and worries earlier. I'm not sure if everybody knows, but all practices are private. There is no opticians run that is owned by the NHS. So obviously we have a bottom line, and to keep us in a profession, we need to make money financially. So seeing all of the hospitals, I don't want this, isn't viable. So it's really good that we have great pathways to allow the people who do need our help, and we can help, in our door, and the ones that are more red flags tend to be sent to the hospital. But yeah, I just wanted to comment on that. I've been to a couple of events recently, and what I've noticed because I work in Berkshire as well as Oxfordshire, is there seems to be a bit of a postcode lottery. So I just wondered what you'd be doing to help the postcode lottery in the form of pathways, really, for people from a optometric point of view, with the changes with the neighbourhood teams. Thank you.
Thanks, Carly. That's helpful. I mean, what we're trying to do as we've come together as one big organisation, certainly trying to manage pathways across different kind of specialities, and optometry is no different. So we're working closely with the lead optometrists, and we have regular meetings with them, and Julie's kind of helping and leading on that. So we will make sure that pathways are equitable across the patch and simplified. One of the things I didn't mention earlier, I think it was in the slide presentation, is that we're trying to make things easier for patients. So the old way of doing business was you went to the optometrist, and you might have got a letter sent back to the GP. It would have kind of wound its way around the GP system and got filed somewhere. The doctor would review it, and then it'd say, like, please refer to the hospital. And then, 2 weeks later, I'd read it and I'd go, right, okay, I need to refer it on. Actually, now there's a system which is electronic, and Julie and the team have been working really hard on this. It's called Rego, where the the optometrist can refer you direct to the hospital. There's no coming bouncing around 2-3 weeks later. It just goes direct to the hospital for routine and urgent. So most optometrists, I think, in the patch are on board with that. So that'll help patients as talking about pathways and making things smooth. You will be able to be referred direct for an urgent eye condition or something routine that needs an eye doctor. But yeah, Carly, thank you for that. We are working closely with the consultants and teams. Okay, I'm going to go back to.
I think there's
John
a Robin
Bosco.
Carr there, or John Bosco. Has he managed to get his?
Yeah, so I was going to go back to John Bosco to see if he'd managed to work out the mic. John, no, still no. Okay,
Hold on, I
carry.
can try and unmute
Yeah.
him at this end. I'm not sure if I can.
Yeah,
Disable mic. One moment. Can you do it now, John? Can you speak?
No,
No,
he needs to have his mic enabled. So I enabled his mic, but he still needs to click it at his end. It's 2 buttons to the left of the leave button, John Bosco, if that helps at all. The big red button in the top corner.
Okay, right. Next, sorry.
You can write your question in the
Yeah.
Q&A and we'll
Yeah,
be
put
able
it in
to
the
pick it
Q&A.
up that way.
Yeah, that's probably sensible.
I
Yeah.
think there's a
thank
Robin
you.
Carr now who wants to.
Yeah. Thank you, Mr. Carr.
Hello, I'm a retired GP from Oxford, and I'm now working with the homeless at a charity in Oxford. Outlined in the draft strategy is something about Oxfordshire had prioritised the homeless as one of the categories they're going to be looking in some care at. Will you be flushing out some of the details as to what that would actually involve, other than just naming them as a group of people who are vulnerable, who require our care?
Yeah, no, thank you. Thank you, Robin. I think, yeah, you're right. So obviously, at the moment, it's very hard. We will get into the detail of that and see what extra services or what extra provision we need to work. So I think we've done a workshop. Louise, can you remind me, or the team? I think we have done, and we've gone out and we've met with some users, and we will obviously take that feedback and look at how the services need to develop. So you're right. Yeah, it's not just kind of in there. We will get to the detail, and there's a lot of detail that still needs to be worked through on this and how we improve those services and deliver those.
Yeah, we've done some additional engagement sessions with some of our more vulnerable communities, including the homeless, travelling families, those with learning disabilities. We've done quite an extensive engagement piece, and we'll use that to inform the next stage as well.
Yeah, thank you. Right, I've got Janet Waters is next. So Janet, yeah, so same instructions. If you can click on the mic and mute yourself. That's it.
Okay.
Yeah.
All right, I'm unmuted now.
Yeah.
Yeah. We have, as a PPG, we've discussed this and submitted some comments. So that I hope those will be helpful in terms of what we like, what we didn't like, what our major concerns were living in on the borders of. We've just had a meeting this afternoon talking about care in the community, literally with colleagues from the ICB. But no, what I was going to say was that I don't see so much about PCNs working extremely efficiently. And I only mention this because I happen to be on a particular committee where we get a number of presentations, and we had the most fantastic presentation from a PCN in Kent, who actually the lead GP came and wowed us all with the way they absolutely are working in a new transformational way in terms of sharing staff, the IT, the digital transformation. And my question to him was, how does this get rolled out across England? And he said, well, we've done loads of presentations, across to many groups, but it's down obviously to each PCN. And then I came back to think about our PCN, that I think works okay. I think from as far as I can tell, in terms of the staff working together, there's not any traction from a PPG point of view. But I just thinking it really is going to take radical transformation. And I didn't read so much about how efficiencies could be made in the PCN group. So that was my first point. And the second point was from the meeting this afternoon, which Julie actually was on. And I think the conclusion that was made by Dan Levison at the end, or in his colleagues, was that this was major system cultural change that needed, real engagement from patients, from clinicians, from staff and whatever, and that was just, we were just talking about discharges and care in the community. And this strategy, you know, my concern is, like all strategies, is the proof will be in the implementation of a major transformation. And we all know culture change is absolutely, most culture change fails. And we know that through, you know, any research that you can do. So my big concern is the, you know, the ability you've got to actually deliver this strategy. And you know, I wish you luck, but I just feel that this is a real, not only is it a challenge, but I don't know, you know, trying to deliver this is going to be incredibly difficult, I think. So good luck. Is my comment.
Thanks, Janet.
Do you want me to take that, Abid?
Yeah, go on. Yeah, I'll let you comment. Yeah.
Yeah, I mean, we chose in the strategy not to define the scale at which we would necessarily work. So within the strategy, there is a slide that explains sort of a system approach, and then a local approach, and then a sub-local approach. And the reason that we've done that is that actually general practice, if we're talking about general practice, they are independent businesses, single units that work on their own, that have their own contracts. If they choose to work as a PCN and they want to take that forward, that's great, and we encourage that. And then, but actually at times there might be the need to work at a slightly different scale, and that might be where the federations come in, or PCNs joining together. So we also have some really good practice in Bob, and things that our PCNs go out to other organisations and talk about, one of which is same day access, actually, with Dr. Amit Sharma. And what we're doing is we're trying to promote a bottom-up change, rather than us telling people what to do. It's more about them owning it and developing it. And then what we will do as an ICB team is to support that transformation, try and unblock where there's issues, and look at how we promote that across the system. So it's something we call service improvement methodology. So it's about small changes that we constantly review, and then sharing of that best practice, and creating communities of practice where people come together and talk about what they've done. So, you know, that's how we'll try and gain some of that cultural shift. We do realise that is going to be hard. People are entrenched, you know, in organisations, or actually in individual roles, whether they're patients or whether they're staff. So, you know, I don't underestimate the size of this task, and you're absolutely right. The proof will be in that delivery plan and the actual outcomes at the end.
Thanks, Louise. Reiterate that it's a big ask, but you know, we're positive and we're confident. So I think with everyone's commitment from all system partners, I'm hoping over the next couple of years we can really make a big change and deliver on this.
But I'd also say that that's why it's really important for us to have this thorough engagement with people. So it's not just about engaging with our public and our GPs, but also those other system providers, so that they understand what it is we're all trying to do, and they recognise the challenge and can help and support as well. So when we talk about that finance challenge that people referenced earlier, actually, if they don't know what our challenges are, they can't do anything. But now, having had all these conversations, they understand where we're trying to get primary care to, and actually how we might go about doing that. And that's the first step on our long journey.
Thank you. Right, we've got Bill McKeith next. So, Bill, if you unmute yourself. Do we need to disable Bill or do anything?
I've enabled his mic, so he just needs to click the mic icon in the top right.
Top right.
Bill, it's top menu. It's near where you see the big red say leave. It's just the second one along, called Mick.
No, it's not clicking. It's not
If your
working.
laptop doesn't have a microphone, that may be why it's not showing up for some people. So in which case they don't have a mic
I think you put a question into the chat, Bill. Should we have a look at that?
Yeah, yeah.
Yeah,
Okay,
let's go
do
to
that.
the
Yeah.
chat. Bill.
So Richard.
While we wait for Bill, we've got one from John Bosco in there.
Right, right. So let's have a look.
Bill, yeah, I've got Bill's question. Do you
Yeah,
want to
if you
deal
yeah,
with
do you want
that?
to read it up? Do you
You've
want to read it
talked
up?
about lack of staff and insufficient funding, and you are inviting us to comment on the consequent reduction in the quality of services. How can you expect us to say other than that we do not want it? I think because there will be, yeah, that's Bill's nodding his head. I think you feel Bill's going to be a reduction of the quality of services through this strategy, draft strategy. Yeah. Anyone going to respond to that, please?
So I think I'll refer back to my other questions. I think actually what we're hoping to do is utilize the resources, what we've got in the system, the workforce, and build on it and actually deliver a better quality for patients, better access, better time, better commitment, better wraparound care, and ideally working on the prevention strategy using the data, the analytics we've got, more upstream work. So we talked about, there should be more investment in that kind of prevention arena. So I'm hoping overall we'll get a better delivery of service. And that's the ambition. Sorry, Bill, your mic wasn't working. Yeah, we apologies for that.
Am I able to read you John Bosco's question that he's put into the chat?
Yeah, sure. Yeah, we'll come to John Bosco's
Thank you.
question, yeah.
So, and that one is, what evidence is there that we will not end up multiplying work across the system so that patients go through the new system and still end up going back to their GPs for the same thing because they feel more confident in that setting? And can surgeries opt out of this without being penalised?
So we're hoping if we get the patient to see the right clinician at the right time, there won't be any moving around, and that's the whole point, that we've got good, well-trained staff and they can deal and close off those episodes. But you're right, we don't want a system where patients don't feel that they're getting the level and the quality of service. So, for example, if I just say in my practice, we have 4 physicians associates, and we're a large training practice, over 22,000 patients. We train physicians associates, we train doctors, train nurses, and we've got 4, 2 who've been there for 3 years and 2 who we've just taken on now. And they each physician associate, every case they see is supervised. So the doctor, the duty doctor, goes through those cases. So on Monday I was duty doctor, and I had 1 physician's associate reporting to me in the morning. I went through, sat down with her, debriefed on every single case where she wasn't sure, made sure that there was a quality check for everything, and where things needed changing, we would go deal with the patient. But most of the stuff was reviewed. And in the afternoon, again, I had 2 physicians associates. I went through all their cases and the urgent cases they'd seen, and with a full debrief, full quality control. And all the doctors, we've got a rota for all the 10, 11 partners in my practice. We do that throughout the week. So if there's something too complicated, perhaps for one of the additional roles staff, then you can move patients up and down. So you could, if they end up, let's say, with something that's beyond their clinical competence, then the GP would need to deal with it. So there is a quality check there. So I understand patients' concern, but there should be those mechanisms in place, and most practices will have that. And obviously, there's been stuff in the press otherwise, and where bad practice is, that needs to be rooted out. So I'm hoping patients, will be managed in the best possible way. And it's not a question of opting in or opting out. What we want to do is have a system. So there's no compulsion here. We want a system that works and works together. So when nobody's going to be forced to do anything they don't want to do, the whole point of the strategy is to have kind of parameters and kind of a vision of going forward and trying to get everyone working at the best possible way and joined up care as best as possible. But we're not going to dictate to anybody, and nobody's going to be penalised. So I just want to ensure there's been no penalisation. There's nothing's going to be forced on anyone. So hopefully that reassures you on that point. Right, I've got a few more hands up.
Just Graham Shelton quickly in the chat. What can we learn from other ICBs and also from other healthcare systems in the world? Can you just answer that one quickly, one of you, please?
Yeah. Louise, do you want to pick that up? Yeah.
Yeah, no, that's fine. So alongside the strategy, we do have a document which is a best practice document, and that has all of the best practice both internationally, nationally and locally. So we have tried to bring that into our document. I think one of the areas that we do like is ClearLit, which is the Israeli model of care, where they are very good at using a technology. They spend a lot less per population than we do, but their outcomes are better. So and actually they call their GPs their consultants. So it changes that dynamic slightly, and what we think of our usual general practitioner, they are highly skilled, highly trained individuals that need to be at the forefront of that care. So yeah, we're doing a lot of sharing.
Yeah, thank you. And there's some good examples in the full document. I think we've highlighted. So okay, I've got a few more hands. So
I think Pauline Murphy has got a hand up.
Yeah, thanks, Richard. Yeah, Pauline, thank you.
Yeah, thank you. I'm just a patient. I'm not medical in any sense of the word. I just wanted to make a comment that if certain people are having difficulty in unmuting themselves, what hope is there for some people that don't want to use the NHS app and have to find some other way around to deal with it? And secondly, talking about physician associates just now, and I know that you would have had to have spent time with a physician associate to go through their cases with you. So that means that you are not doing GP work because they're supposed to have taken that away from you to give you more time, and then you're spending the time sorting them out.
Yeah, you make a valid point. When we debrief, it's not taking up significant amounts of time unless it's something complicated. But we're a training practice as well, so the more junior ones, so the more senior ones, it's not onerous, but the more junior ones who need to be trained up, they need a bit of time spending on. So it's worth investing that time with any. It's like a trainee doctor. You have to go through all the trainee doctor cases and review them as a trainee partner with a GP registrar. It's the same process. So you have to, if you invest the time and you invest it well, then you reap the rewards later, where when you're doing a debrief, it's a fairly quick thing. And you only discuss anything that they're worried about, which may be 1-2 things in a whole session. So you're right. And on the NHS app, I think what we want to do is make sure that we're looking after our patients who are not so au fait with the NHS app or digital technology. So Julie, I don't know if you want to come in on that point.
I would use the NHS app, I'm afraid. I don't see the point of it.
Yeah, the NHS app does have a lot of advantages for many, but it's not in there for everyone. I think we get the highest usage of it for ordering repeat prescriptions. So it can all be done through the NHS app. The message goes straight to the GP surgery, who then activates it. You now also get a way of monitoring where your prescription is at, which will save phone calls to the pharmacist or to the GP. So I think I agree with you. It's not right for all, and actually we need to help those that can't use it to maintain normal access. But in some ways, it's good for me. I can order my prescription in the middle of the night after I've got home from work without thinking, oh, I've got to call up the practice. So agree, it doesn't suit everybody, but I think it does really help. And we shouldn't forget about our vulnerable populations who are not maybe digitally literate or need some help and other ways of accessing general practice and all our primary care services.
Yeah, and we've got to make sure that those patients are absolutely catered for. So that's a must. So Pauline, we did something at my practice working with the PPG. I think it was the Saturday before last, and we had over 50-60 patients, okay, they were of a certain age, and where they'd never used the app. They were worried about the NHS app, and I had 2 80-year-olds who'd never used it. They had it on their phone, but they were too scared to push the button, and we helped them set it all up and work it, and they were amazed as to what they could do with it. And we helped 50 patients plus that day, who could, we showed them how to use the app. We had loads of volunteers from the PPG and others, loaded the app, so got it set up if they're having problems, and we're going to probably be doing similar events. So I think you're right. There is some nervousness out there, and it doesn't suit everybody, but there's a lot of people out there who are like just a bit worried, but they have got it and they can use it. And if we can encourage those, then that's good. But we need to make sure we cater for the learning disabled, those with other vulnerabilities where they need to access the practice in the traditional route and be able to either the carers can or they can. And I think that's important. We mustn't miss that. So I'm just conscious of time. I've got another hand. I think Alan Cohen is next. Alan, so if you can unmute yourself, that'd be brilliant. Thank you. No. Okay. No mic button on the top right. You have, but you can't unmute it. Oh, is Alan disabled? Do we need to disable Alan?
Alan, try and put it in the Q&A and we'll have a look at it, please.
Yeah, his mic's been disabled. Sorry,
so,
I've enabled his mic. Sorry, but
yeah.
Yeah,
If
sorry.
not, Alan, do you want to pop it in the Q&A quickly? We can pick it up. And while we're waiting, I think Tim, hello, Tim is on our board, has put in it to have a look at its commentary and the questions and answers as well. So obviously, Tim's saying that it will be a challenge, but you know, the strategy gives us a kind of a practical way forward and on how to support this. So thank you, Tim, for that. Be supportive. So yeah, Alan, yeah, if you drop your question in, we'll pick that up now before we close.
There's a quick question, Abid. Do we have representation for all primary care settings at our PCNs? As far as I'm aware, we do not.
Okay, so yeah, you mean
that was from a Carly Warner. Do we have representation for all primary care settings
in the network?
As part of our PCN?
So I think Carly is our optometrist on the call, and I think she was asking whether we have pharmacists, dentists, optometrists within our PCNs. I think that's certainly our aspiration. We're seeing GP practices work much closer with pharmacists and even employ pharmacists now, as well as linking in with their community pharmacists. And I think our aspiration as part of the work on the strategy has been to bring the four pillars much closer together. I don't think we're there yet, but I think those that we need to link between those pillars of primary care as important, or facilitate that so that we can get that embedded.
Okay, thanks, Julie. Alan looks like he's still typing away. So, Joan, just about your comment about just 3 hubs across the whole of Bob. It's not. I don't think that's what we're proposing. It was a kind of a mod. We need to look at the model. We haven't worked up the detail. So, Oxfordshire, Berkshire, Western, Buxton are big geographies. You're right, and we're not proposing a single kind of hub. And remember, this is not for everybody. As I've already explained, what we're not doing is splitting a kind of elective from all urgent care access. Some practices will be absolutely fine. I can't see my practice, for example. We've got a good setup. We workflow the work to the right clinician in the practice, and we have loads of extra urgent slots on the day, and above and beyond what we're already delivering. We've taken on an extra doctor, so I don't think we'll be using any. Even if there was a hub in my patch in West Berkshire, I'm not sure we'd be accessing it much, but we may do. You never know. Things can change quite quickly from a strong, resilient practice to 1 or 2 partners retiring, a sickness. Something can happen, and before you know it, you can be a bit of trouble. So I think we need to what we're trying to do is come up with a model which will help those practices who need it, if they're overflowing. And otherwise, what happens is those patients, end up going to 111, getting bounced around the system, and that's not good as well. So the detail needs to be worked up. So and we'll obviously work through that. So Alan, have you posted? Just nod if you posted your question, so I can't. Is that yeah? It has. Okay, let me just see if I can pick that up.
Alan's question is: there is a Cochrane review and a King's Fund report that demonstrates that these models of care increase inappropriate contacts, not reduce contacts. Further, the idea of triage on the same day and same-day care undermines the principles of primary care. It has been described as a swamp and is complicated enough for a highly trained GP to disentangle and a presentation, let alone an algorithm-led receptionist. Speaking as a retired GP.
Yeah, thanks. I mean, I think what we want to try to we've like I said before, we've got a problem with access. Patients want access, and patients want it now. We're living in that kind of culture where they want to be seen and they want convenience. Some patients obviously want to see their GP and only their GP and their own GP. Other patients don't mind; they're quite happy to use technology. So I think we've got to come up with something that's sensible with the workforce and the pressures we've got in the system. So what we're trying to do is deploy, and we've got to move with the times as well. What we're trying to do is deploy, certainly something we're looking at in West Berkshire, using the technology to triage and help us triage the right patients to the right profession. So I think, yes, it's complicated, but we're trying to simplify it and trying to get the patient to the right person. And it might have been different to perhaps, when you practiced, if you're not still practicing. But we've got to look at systems, and we've got to see what we can do to move forward, because as Tim outlined in his post, staying the same is not an option. We haven't got the workforce, and the graph, as you see in the draft strategy, shows if we did nothing, the demand will just continue going up over the next 10 years. And we know we've got difficulties with recruitment, retention, workload. The problem list goes on. So, and I think it's about, if we change the model. So on the King's Fund report, it talks about shifting resource from different settings into the primary care. So I think what we're also saying is we understand that, and we've got to look at the model of care for primary and community. And okay, it's a difficult financial environment, but we've got to make sure we can use the resource we've got in the system to move it to where it needs to be in the community and in primary care, the wider primary care, and get to patients earlier. And if we can look after patients earlier and better, therefore it reduces their demand further down the line. We can do all the prevention stuff we talked about. If we can make sure patients are not bouncing in and out of hospital, acute urgencies, because we've already got a team who are looking after them, and we've got a different model of care for looking after them. They're not going in as an acute emergency, sitting for hours in A&E, trying to find a bed, going in, having a few investigations, coming out. So I think, like I said, if we can get this right, I think it can work. We've got to be optimistic about this, and we've got to try and deliver on this over the next couple of years. And it's not easy. It's a wicked problem, because if it was easy, systems around the country would have solved it. Look, we're 5 minutes over time, and I just wanted to thank you for all your kind of feedback and engagement on this. Really been excellent. I think really been really good to see you all, and we've had a great turnout this evening. So we'll feed all that in. Take note of your comments, and if you've got anything else, please use the I think it was on the slides.
The survey, yeah, you can go to the engagement platform, which is your voice, Bob. The links on the front page of our website, the Bob ICB website. So you've got time till the 29th of Feb. Please share your views with us on the strategy, the draft strategy, and that's on the platform as well. You can read, and this recording will be made available on that engagement site, so you can see the presentation that Abid and Louise went through. And Julie Dandridge, thank you very much for taking part.
Yeah, thank you everyone, and have a nice evening. Cheers.
Thank you.
Okay, bye-bye.